Hey, hello. My name is Letitia Elopre, and I'm an infectious diseases provider at the University of Alabama at Birmingham. Today, I was asked to speak really about how the HIV pandemic has affected the Southern community and specifically the Black community, which is something that I'm very passionate about. My career as a physician and my career as a scientist is focused on how to improve the lives of Black people living in the South, and specifically as it relates to the HIV epidemic. So, I want to just share some of the things that I've learned on that journey with you, especially as we're approaching the 40th anniversary from when the first case of HIV was reported by the CDC. And here are my financial disclosures. So, to begin, I want to start with why I was drawn to research to begin with. And really, I think that my story begins like a lot of Black people's stories begin, especially people who lived in the South, where you know someone, and specifically for me, it was my uncle who had HIV. At the time, I did not know that he had HIV. I did not know until after he had been dead for probably about 10 years. So he died in 1992 at the age of 28. And what I found out as I became an adult was not only did he have HIV, but he was a young gay man living with HIV in a world that really didn't accept him. And I think that that in large part led to why he had the outcomes he had, and that is where my journey has begun in trying to improve HIV outcomes and prevention in Black communities. And so, in the initial stages of my research journey, I thought, okay, he died in 1992. If he had made it to 1996, where we had highly effective HIV therapy, his story may have been different because he would have had one pill that he could take every day. And what we're seeing is that that is not the case. And I have this picture up because I think this is one of the first times that our national news media brought to attention to the rest of the US that there is a hidden epidemic happening among Black, gay, and bisexual men who are living in the South, where despite having this wonderful option, this tool where if you take a pill every day, you can live as long as someone who doesn't have HIV. You can not transmit the virus to your loved ones. If you take your pill and you become virally suppressed, so we do not see virus in your blood, you cannot transmit. Despite that, we're still seeing higher rates of HIV among Black, gay, and bisexual men, and especially in the South. And this has led to national initiatives to try to improve the epidemic in the South. And what I want to do, because I was seeing so many young Black gay men coming into clinic in tears with feelings of shame, is I said, how can we prevent this from ever happening? And so I became very interested in something called HIV pre-exposure prophylaxis, or PrEP. And PrEP was approved in July 2012. And essentially, if you take this pill every day and you do not have HIV, if you're exposed to HIV, 95% of the time, you will not get it. And it's amazing. Again, this wonderful toolkit that we have available that could change the epidemic, change the fact that even though the South has less than half of the population, we have over half of new HIV diagnoses. Change the fact that we're seeing the highest rates among Black, gay, and bisexual men, and change the fact that we know that Black women are 9 times more likely to be infected with HIV compared to white women. So all of these inequities, you have this tool. But what we've been seeing nationally is despite the fact that we know based off of who's most likely to get infected with HIV, which is Black, gay, and bisexual men, as well as Hispanic or Latino gay and bisexual men, they're not being prescribed PrEP. And so this wonderful tool, again, this wonderful intervention that's been created is not effective, is not having the public health impact that it potentially could have, and specifically not in the South. And so as I was starting to, I think, develop as a scientist and talking more to community partners, specifically AIDS service organizations like AIDS Alabama, and asking them, why are we seeing what we're seeing? What do you think is the answer? They said, it's not that you have this great tool, it's the stigma, it's the structural barriers, it's all of the things that we have to deal with in our day-to-day lives that impact our ability to access PrEP. And that's what needs to be intervened on. That's the story that needs to be told so that we don't have a young Black gay man standing on a road by himself in Mississippi on the New York Times cover, really carrying the burden of the epidemic on his shoulders. And so I've done a few studies, but I want to bring to light some of the studies I've done, which really was just talking to people, doing interviews and trying to understand how having multiple identities, being Black, being gay, living in the South, how all of that impacts your ability to access PrEP. And these young men shared stories talking about the fact that they, yes, had all of these identities that were stigmatizing, but more so, the interactions that they had with people were impacting their ability to access PrEP. So this young man said that um, the high risk sex that young Black gay men may have is an act out of the validation they don't get from people who they feel like they should get it from. Another individual said, I feel like a lot of us hide what is that we're going through or what we actually are just because we can't be open about it. And that kind of hurts us even more because we don't go to health departments and get tested. And then this last individual, and this is a theme that I commonly saw, talked about the joy and support he got when especially Black women in his life accepted him. And he talked about his grandmother, how when he came out to his grandma, she just hugged him and said, Jesus still loves you. I love you. Do your thing. And that allowed him to accept himself. And so I think what we're moving towards now, really as investigators and as a nation, is saying we can't just focus on one individual. This is about a population. This is about a Black community. And if we want to improve the lives of young Black gay men, we need to not only understand how all of these intersecting identities impact them, but look at the relationships that they have with their loved ones, with their mothers or sisters, with other Black gay men, and with their friends, and then look at how they interact within the Black community. So you have to attack this on multiple levels. And what this really led to was another discussion I had with another AIDS service organization I work with called Medical Advocacy and Outreach, who said, it's great that we have this cover, but we need to talk about women. We can't just talk about one individual. We need to talk about all individuals because a whole community is inequitably impacted by the epidemic. In order for us to move forward, we have to actually address that. And as I said, Black women are really facing huge inequities when it comes to HIV rates. Right now, about 1 in 5 women make up new diagnoses for HIV, and 70% of those women are Black. So, how can we help Black cisgender women use prevention tools like PrEP? And again, what we're seeing is PrEP is not being used by Black women. And unfortunately, the majority of PrEP prescriptions are written for white, gay, and bisexual men, followed by other, and when I say other, I mean our minority, underrepresented Black, gay, and bisexual men, and Hispanic, Black, gay, and bisexual men. But what we're not seeing is really any prescriptions for cisgender women. And so, again, understanding how all of these overlapping, intersecting identities, the stigma they face due to their race, due to gender, due to poverty, or any other aspect of their culture impact their ability to access PrEP. There's been a lot of work in this space, looking at all different types of barriers to PrEP. A lot of these have been survey studies that have done by other investigators, and some that have been done by myself that have shown that women in general, especially Black women, feel like they don't know about PrEP. There's a lot of distrust when it comes to medical systems. There's concerns about cost, the effectiveness of PrEP. Most women do not think that they're at risk. And in honesty, we do not have a full understanding of what puts women at risk for HIV. So really trying to get out of that discussion from a risk standpoint probably is best. And there's a lot of stigma related to HIV and PrEP. And again, in the work that I've been able to do, I think that some of the most moving things were in the conversations we had, trying to understand the lives of Black women. And I was able to do a study that not only spoke to Black women living in urban settings, but Black women living in some of the Black Belt regions of the South. So areas in the South that are called Black because of the Black soil that was told by slaves hundreds of years ago, and after that by sharecroppers, and to this day by Black people, with high levels of poverty, high levels of structural racism. And I really want to talk to these women because I knew that their stories were going to be so impactful. And ultimately, what I heard across the board is stigma, stigma, stigma. Stigma is the key. One of the reasons that people are not able to access PrEP, and that when you're talking about the lives of Black women, especially Black women living in rural communities, they feel like, number one, they have so many other barriers related to how they're going to eat, how they're going to feed their family, and then how are you going to access PrEP in a way where people aren't going to know that you are accessing PrEP, and tons of distrust for our systems that, again, are from historical trauma that has occurred, but also current trauma that's occurring on a daily level in their lives. The other thing we were able to do is try to understand what they want when it comes to service delivery preferences. And, I think that it was one of the most impactful studies I was able to do. We surveyed over 790 women across the state of Alabama. And based off whether they lived in an urban area versus a rural area, also kind of told us what they desired. But a lot of Black women said, where you're offering PrEP for Black women at STD clinics and family planning clinics, we don't necessarily want it there because those areas, unfortunately, are stigmatizing in and of themselves. We want to be able to go to our gynecologist and get PrEP. We want to talk about other types of PrEP modalities like long-acting PrEP, especially in in rural communities where I may not want to go to my doctor on a, frequent basis. I might want to be able to talk to them at my home where I don't have to be concerned about running into someone that I know as I access PrEP. And again, what I want to point out is that when I was talking to these women, the biggest aspects of them being able to access PrEP wasn't just focused on them themselves. It was focused on the relationships that are going to be impacted by them accessing PrEP, the community support that they would receive, are there concerns about how they would be perceived by their community while accessing PrEP. And these are things that I think, again, all of us are moving towards trying to understand how on multiple levels we can improve access to PrEP. But by and all, one of the biggest barriers that even if we were to address stigma, we were to change and garner support among relationships that people have with close loved ones and within Black communities, in order for us to truly be able to improve utilization of prevention tools like PrEP and improve HIV rates and outcomes, you have to have system level changes. The healthcare systems need to change. The implicit, explicit, and systematic biases that are present within our healthcare systems have to be addressed, and you have to have policy change as well. And that's where advocacy comes in. I think that the results that we have in these studies are impactful in that they can be used as tools to inform the policies that are made that affect the lives of Black people, especially disenfranchised Black people who are living in Southern communities. And what I want to close out on is one of the best examples that I know of Black people and Black communities coming together to fight injustices, and that's the civil rights movement. This is an example of, again, not just looking at the individual, but relationships and communities of Black people coming together to boycott a system that was implicitly and explicitly biased and racist towards them that were affecting their daily lives and led to legislation change. And this is, I think, the type of mobilization and social capital that's going to be necessary for us to improve not only our lives in the aspect of HIV, but holistically. And that's really I think, the future of this type of research and the future of us hopefully seeing a change in the pandemic and the epidemic of HIV is that we're going to have communities come together to force policy change. So I want to give a special thanks to Medical Advocacy and Outreach, which is the community that I was able to work with on most of these studies, and also Southern AIDS Coalition for giving me the opportunity to speak to you all again on the anniversary of that first case of HIV. And I just want to leave with hopefully the inspiration that I think is possible to change. So thank you.